But I think it would help if the payer defined the question somewhat. So, for example, if we look at the sequence of drugs that we've elaborated, the current situation is of sequential use where if the patient's appropriate, we're going to try and give every drug. All right. Now, we know, as Michael just said, that every patient is not going to respond to every drug. So as a clinician, what I'd really like to do is I'd like to have something that tells me either before I start, listen, this drug will not work in this patient, or I think we're closer to this. After just say one cycle or 1 month of treatment, this patient is not going to respond. And we went here in the early days of docetaxel with the SWOG 9916 data to try and look at PSA surrogacy. And the surrogacy for PSA response with docetaxel is it's kind of there at somewhere between 9 and 12 weeks, but you've already started to get toxicity in the patient. And you will make a decision anyway, probably based on some other factors that are around about that point. So, and some of the newer things that have come, so we're working with circulating tumour cell enumeration, which at the moment is actually quite expensive. But we have data now for docetaxel and also just recently for abiraterone presented from one of the Cougar studies to show that after 3 to 4 weeks, you can tell who is not going to respond to docetaxel chemotherapy. Now, it begs a question, we haven't quite got there yet. Just because your CTCs don't go down on one of those treatments doesn't mean that you should give up the treatment at that point. But we're probably going to need to do some sort of trial, and it may not be a conventional cooperative group study, except that I don't know whether the companies are going to want to do those trials either. So we're going to have to develop a new paradigm for addressing and looking at this question to say, okay, you got a patient on abiraterone, which is an expensive therapy, and their CTC profile at 4 weeks is not good. Do you continue them on abiraterone or do you switch to docetaxel? That switch, potentially, if you make the right decision, could be good for the patient and good for costs, could reduce it. And testing that, for example, in a paradigm is somewhere where we're able to make a decision now because we have choice. Designing the trial is not that hard. I think we have the technology. Funding the trial and moving through the comparative effectiveness paradigm, which is not what we've done. We've been trying to win all the time, rather than compare effectiveness. It's a different sort of endpoint.
So I think the real question is this, right? So we have these approved agents. I think we can agree that the pharmaceutical companies are really not interested in knowing the answer to some of these questions because it would significantly impact market share. We also can, I think, uniformly agree that the current state of health information integration is, it's embarrassing, right? So things occur in academic medical centers, things occur in clinical practice. All those potential phenotypic and genotypic signals that might tell us what to do, for all intents and purposes, are lost. They're not aggregated. They're not collected. Are there enough people out there who have been treated in a certain sequence for us to be able to hazard a guess as to what the right way to go is? Now, this is not randomized clinical trials. I think you could easily argue that in the contemporary era, particularly when we start talking about personalized medicine and therapy driven by the mutation profile as determined by exome sequencing, that trial paradigm just doesn't work. It just doesn't work. It doesn't give us answers quickly enough. So if you were going to spend money and try to get the biggest bang for your buck, it seems to me the idea is to get that information aggregated, sorted, reported, analyzed in a useful fashion. I think actually there will be solutions that come from the private sector. Now I'm going to suggest to you guys, you may not like what they come up with, okay? But there are companies that can structure data from free text and unstructured fields, can put it together in an actionable format, marry it to claims, and give us an answer. And those guys, they're going to be peddling their services to managed care companies to help us make decisions about, well, step therapy. What should go first and what should go second? So I'll give you a funny anecdote. I was meeting with a cancer center director, and he said to me, You're just trying to turn doctors into cooks. They want to be chefs. And I thought to myself, well, my mom really was pretty proud of herself because she thought she was a good cook. She never aspired to be a chef. She made sure that the right food was on the meal every day. And we have to think about managing cancer from the population perspective. How are we going to make decisions in today's healthcare environment that are going to make the best of a challenging situation? And to me, that's what we have to do. Now, I'm not against innovation. I'm totally for innovation because I think there's going to be tremendous opportunities that are going to come out of those exploratory analyses. But to say that I think it's going to work for somebody because I think it's a great idea, those days are over. They're over.